So, good morning, and thank you very much for inviting me to speak. What I'm going to be doing today is really do a very simple talk, but sort of give you the direction on where the treatment for these, what we call embryonal brain tumors, which include medulloblastoma, PNET, and ATRT, are heading. So the headline is just going to be one slide on the demographics, and then give you a little detail about the medulloblastoma and the subtypes, because that's the field which is the most advanced, and then just show you some very, very recent, and by recent I mean this year, papers which have come to dissect out the PNETs and the ATRTs, and then just a little peek into the kind of research we are doing to improve the cure rate, but also reduce the toxicity, because that's, as many of you have recognized, is an equally important area to advance our field, and then some future directions. I think, you've seen this slide before, and really we're dealing, what I'm going to be addressing are the embryonal tumors and medulloblastoma, which totally make up about 15 to 20% of all brain tumors in children. The main issue is that these are the most malignant tumors and fatal if not treated appropriately. So focusing on medullo, I think the previous speaker also mentioned, this is a tumor which arises at the back of the head and is often described as morphologically under the microscope as having small round blue cells. Often this tumor has spread beyond the back of the head or the posterior fossa, either in the CSF or the spinal fluid, or lumpy disease in the brain and the spinal cord when it's called metastatic disease. So currently, the treatment for these is very similar with the chemotherapy. The only difference is the dose of radiation therapy. So the children which have the tumor removed totally and don't have any spread get a lower dose of craniospinal radiation therapy. The children which have tumor spread get a higher dose of radiation therapy. But otherwise, the disease has been treated fairly evenly. And really it's the last decade where we've recognized that this is not a homogeneous disease. This is a disease which is made up of 4 different subtypes, and at the end of this meeting, Dr. Paiza sitting in the corner, those subtypes are going to be further dissected as we're learning more and more about these tumors. So this is just a GWIS slide just to sort of show you the kind of data we generate. If you look at the RNA expression, you can see that the RNA in each of these tumors are different, and you have a different pattern which emerges. Another way of looking is areas of large chromosomal gains or losses. The blue are the losses, the red are the gains. And again, as you see, the different subgroups have very characteristic patterns of chromosomal gains and losses. And if you just focus on the top one, that's the Wnt tumors, which have uniformly loss of chromosome 6 or monosomy 6, which is a telltale signature for these tumors. And then again, within each of these subgroups, the genes which are present are very mutated depending on the subgroup of the tumor. So you can see what is mutated in the first subgroup is not mutated in the second subgroup, and so on and so forth. So when you integrate all of this together, you get an output like this. This is a methylation profile. This is what a lot of parents are now requesting, and data which is being generated from these tumors. And this, for example, is a group 4 tumor. You can see on the very far corner amplification of the CDK6 gene. You can see these large chromosomal copy losses and gains. So green are the gains and red are the losses. And also you can see that there's a mutation in a particular gene called the PIK3CA. This is generated by sequencing. So this, though in the research realm, is very rapidly moving into clinical diagnostics. And this is the kind of information which is going to be absolutely driving our decision making on therapy in the future trials. And in fact, Dr. Gillian mentioned about the Wnt trial, which is going to open up in Europe. That's exactly the kind of molecular testing that's going to be done to pick out these patients so that they get appropriate therapy. And if you integrate all of this, you get a map like this. This is a sort of a schematic which separates all these 4 subgroups. It gives you a lot of demographic information, the age of the children, and I'll go over that in the next slide. male-female distribution, presence of metastatic disease, which are the typical genes which are affected, and on top of that, if you layer, this is what you get. You see that blue line is the Wnt subgroup, which does extremely well, and then you can see the group 3, the group 4, and the sonic hedgehog with the yellow, the group 3 doing the worst. So when we newly diagnose the patient, it's no longer sufficient to just look under the microscope and say you've got a medullo. We need this kind of information. And so the question is, if you're looking at an infant, it's very likely the child will have either a sonic hedgehog or a group 3 tumor, and a very small percentage of the patients will be group 4. And as I showed you, that these group 3 tumors do worse. If you're looking at the pediatric age group, you have all 4 varieties which are represented. And then when you go back to the adults, majority of the tumors are sonic hedgehog and group 4 with a small sliver of Wnt tumors. You don't see any group 3 tumors. So it's very essential to know what you're treating and what you're dealing with so that you can start directing therapy for these patients. So the question all of you will ask is, oh, this is all great, you get all these papers, you guys are in the lab running around, why the heck does it, what difference does it make? What do these subgroups mean? Are we getting excited with a bunch of mutations and chromosomal alterations? And what's the clinical drag? And what is the change in the treatment? How is this going to direct the change in the treatment? So this is just the 4 subgroups. This is a paper that we wrote, and basically using this as a transition to move from our previous protocol, SJMB03, to our current protocol, SJMB12, where we are really now directing the therapy based on the molecular subgrouping and the clinical risk. So if you just look at that first column, the Wnt column, if you see the patients, how they're getting treated, you look at the first subgroup, these are the patients which have tumor completely taken out and have no metastatic disease. We've dropped the dose of radiation to just 15 gray craniospinal with a short adjuvant therapy. So this is a group of tumors that does very well, and there's an opportunity to now cutting back on our standard therapy. You can't improve on a cure rate, which is almost touching 100%, but what you're doing is then cutting back the long-term toxicity of these patients. So this is just an example. This is a trial for newly diagnosed medulloblastoma, and it's the first sort of trial which is molecularly targeted to all the different subgroups of medulla. So I'm just going to give you a quick example of a child. Actually, this child was the very first child who was enrolled on this study, and this is medullo. Now I can tell you just from the location that being lateral hemispheric in the posterior fossa, this is most likely to be a sonic hedgehog medulla. So this was the history. This was a 4-year-old female with a 2-week history of headaches and stumbling. The MRI noted the right cerebellum mass, which I showed you, but here comes the kicker. The family history of medulloblastoma in the patient's father and aunt, who were both treated at St. Jude. So we knew the family history. The father of this child was also treated for medullo at St. Jude and had a resection done almost 3 years ago by a neurosurgeon. And the pathology showed that this was a desmoplastic variety, which we could predict from the location, a sonic hedgehog tumor, and subgroup by immunohistochemistry, and there was no significant anaplasia in the tumor. When we did the molecular subtyping, you looked at the genes which are most commonly affected. There was amplification of MYC-N. Again, that's technical. We can forget about that. The PAT gene was deleted. There was no application of MYC-C, and P10, which is another gene, was normal. So the question then becomes, the father had it, the aunt had it, now you've got a child who's been diagnosed. Could this be a germline transmission? Is this something that we need to be careful about? And could this child be a Gorlin syndrome patient? So this is a particular sort of syndrome which is transmitted in families who develop medullos but also have a predisposition to develop basal cell carcinoma and dental cysts. And if you give craniospinal radiation to these children, at a certain time they'll all come down with basal cell carcinoma. It's a very morbid situation. So since we had the family history and we did the entire molecular workup, we treated this child only with focal radiation therapy and introduced a targeted drug, the smoothen inhibitor, and she's just came for a checkup and she's completely tumor-free 3 years post-diagnosis. So this is just an example. I can tell you many more stories, but just an example where all of this lab work and all this advance actually is making a real difference in the clinic today so that we can adjust therapy based on these patients' risk. So again, for the Wnt patients, we're cutting back the craniospinal dose. For the Hedgehog patients, we're adding molecular targeted therapy. And then for this third group of patients, we're adding some new chemotherapy, which is directed particularly towards this aggressive form of medulloblastoma. This is a research study. We have accrued 155 patients. We'll hope to finish it and then share the results at future meetings at the ISPNO and then move the field forward. So moving to PNET, again, this paper was just published in February of this year. And again, as other speakers have mentioned, these are small round blue cell tumors, which are areas on the top of the head, not at the back. If they're in the back, in principle, they are called medulloblastoma. And again, collecting these globally in Europe and from North America, studying large number of patients, this is what we need to cooperate, and that's why these meetings that we have on Monday through Wednesday are very important, is because we can get together and decide what studies we're going to do in the future. We recognized that this disease also has 4 different subgroups. You can see the different subgroups which are listed over there, and I'm just going to give you one slide on each of these subgroups because that again sharpens our understanding of these tumors. So this CNS neuroblastoma, FOXR2, you can see the distribution of the tumors which are present all over the head. This is a younger age group where these tumors are present, and this is a female predominant disease. So in a younger child with a supratentorial tumor, you'll most likely be thinking of a FOXR2 subgroup. The MIN1 tumors, you can see they're supratentorial, but you can also see there are some tumors in the posterior fossa. So even though we say most small round blue cell tumors in the posterior fossa medullo, if you have the sort of genomic insight, you can pick these tumors out. This is a heavily female predominant disease and occurs in an older subgroup of patients. This bcorps is again in the younger subgroup, male predominant. You can see the incidence both supratentorially and in the posterior fossa. And this last subgroup, the CIC group, again is an infant disease with male predominance. And why does it matter? Because we know that each of these subgroups have different outcomes. And you can see that the best subgroup is the MIN1 subgroup. So as you're talking to families and they come to you, it's no longer, again, hammering the same point, saying you've got a PNET, we need to know what subgroup you are, and then we can adjust the therapies. If it's a bcorps, you know the child is going to do poorly, and I think in today's day and age, the parents need to be informed about these decisions. So in summary, for the PNETs, these are often misdiagnosed as high-grade gliomas. This is another subgroup of embryonal tumors, and even some patients which are diagnosed as ependymoma. The new defined 4 distinct molecular entities have overlapping pathological and clinical features. So just studying the tumor under the microscope is not going to help. We need to have the molecular differentiation. The outcome data which I showed you needs to be proven in a prospective series. This is just a small retrospective sample, and we are now working on studies which will actually prospectively confirm this data. And this is a subgroup where we need to develop novel therapy. So switching to ATRT, again, this is a rare subgroup of tumors. It was only recognized about a decade ago. This tumor has familial, germline transmission in about 20% of the patients. You have a strong family history of other tumors. If you just ask, the parents will tell you that. And again, using these advanced techniques which I just introduced to you, DNA methylation, the gene expression, the sequencing, and then further sort of different types of sequencing, you can split this ATRT tumor out into different subgroups. So there are 3 different subgroups of ATRT, the tyrosinase, the sonic hedgehog, and the MYC amplified. And then again, you can see between the supratentorial brain and the infratentorial brain, depending on the subgroup, they vary. So the tyrosinase essentially is in the posterior fossa, whereas the MYC amplified is a supratentorial brain disease. You can see the sex difference between male and female. The tyrosinase is almost 50%, whereas the MYC amplified and the sonic hedgehog are male predominant diseases. And again, within an age group, you can see the difference in the incidence of the different subgroups of ATRT. Again, important to know because each of these subgroups behave differently clinically, and we are hoping to now start developing specific targeted therapies for each of the subgroups of ATRT. And this, again, you can come up with a chart similar to the medullos where you can start separating these tumors out and looking at the genes which are affected and then start adjusting the therapy based on this. So again, in summary, the molecular and clinical subgroups are defined by the genomic techniques. the epigenetic landscape, may give insight to molecular pathogenesis. And I think when Dr. Karen was speaking, you were asking for which are the therapies. So these are this is all, means not much to you guys, but these are the type of drugs we are working on, the EZH2 inhibitors, HDAC inhibitors. We've got a trial currently ongoing with aurora kinase inhibitors in frontline, and the CDK4/6 inhibitors, which are rapidly coming into clinical trials. The phase 1 studies are already completed and ongoing. So again, we think that now that we know the different subtypes, we can start approaching each of these with specific drugs, along with the backbone of surgery, chemotherapy, and radiation therapy, but then using specific drugs that may be more efficacious than the one-size-fits-all and throw the same chemotherapy against all these tumors. So as I mentioned, obviously we want more children to be cured, but the other part that we are working on at St. Jude and several other big places is how do we reduce some of the side effects that these patients face, because this is not a simple task. This is a lifelong morbidity that these children develop. And some of the things we are doing is looking at genes which are predisposing to hearing loss. So if we do this at the beginning, we know that these particular SNPs are present. You can adjust the exposure to the cytotoxic and ototoxic chemotherapy. We've used amifostine, which is a sodium thiosulfate kind of derivative, which was developed by the U.S. Army to protect soldiers against chemical warfare, but it also protects against hearing. And you can look and see the patients which got amifostine, almost 70% got preserved hearing compared to the patients which didn't get amifostine. And then we're doing a lot of work on the neurocognitive side effects. So this is a severe problem for our patients. The younger the child and the higher the dose of radiation therapy, they are worse side effects. So we're not just looking at IQ. I think IQ was something which was studied almost 2 decades ago. But we are now looking at processing speed, attention, working memory, different subgroups which go on to the composite score of the IQ, look at eloquent parts of the brain which are involved, because now, as you heard, you can now protect certain parts of the brain by developing your radiation therapy to avoid the hippocampus, the inner ear, to try to preserve some of this hearing. But the work that we are doing is trying to have neurocognitive rehab for these patients. And again, for the sake of time, I won't go into that, but this is another big area that we are focusing on. And then we and others are also doing novel drug development, and these 2 particular drugs, gemcitabine and pemetrexate, were 2 which were very effective against our models with the group 3 and group 4 tumors, which we plugged into our frontline protocol. So this is rapid translation of work which we're doing in the lab. We take the tumor, we grow it in the mouse, we test these drugs. Anything which looks promising, we test it again, and then we move it into a frontline setting. So these are the ways that we are trying to make progress for these difficult and rare tumors. So in the future, molecular diagnostic is going to be absolutely important for all tumors. The words that you may use is clinical genomics. So rapidly moving from a research setting to real-time setting. In Europe, the Germans have been kind of leaders in this field, and many patients, when they email, we say, why don't you send your tumor to Germany, and they'll do it. I know in the UK there's a big push, and in fact, some of the investigators are going to be asking the Brain Tumor Charity to fund this kind of work for the UK patients. Offer targeted therapy on the molecular subtyping results. This is another big sort of lingo, precision medicine, blue ribbon panel. I mean, these are the words which are used. This is really finding out which are the genes which are affected and then coming out with rational combinations. I'm oversimplifying it, of course. It's not as simple as, okay, you got this gene mutated, we got this medicine, and we throw it against that, and that's going to save it. But we are clearly understanding more about these tumors and what's driving them, and we're hoping to start addressing them by giving targeted therapies in a single or combination to try to suppress those pathways. This targeted therapy I mentioned about, proton beam. There's been a lot of discussion, a lot of curiosity about proton beam. Whether we like it or not, this has come here to stay, and I think in the next decade it will be clear how much of it is going to help, and the indications for proton therapy will become much clearer. I do think as we go into this era of clinical genomics, genetic counseling is going to be very important for families because you are going to uncover genetic anomalies which are going to have far-reaching consequences, because in the pediatric world, a lot of our parents are young. This is usually their first child. They're worried about their second and subsequent children, implication to other family members when it's a germline transmission. And I think this is an important service that all healthcare delivery systems are going to have to think about, because it's not just okay to generate all this data and throw it at the parents and then expect them to go through it. They need professional guidance, and it's almost insistent in our systems that we provide genetic counseling if we are going to do this kind of molecular testing. And the late effects are something that we pay a lot of attention to, and it's not just documenting them, but actually having strategies, neurocognitive rehab strategies, to start to help these children as they go through school, and providing some kind of counseling adjusted to their functioning level so that they can get a chance of some kind of employment down the future. So I would be amiss if I did not thank all the people. It's a global effort. We've got great friends of mine at Newcastle University, Germans, Stanford, St. Jude, Toronto, and then Boston, the Broad Institute, and then all the institutions which take part in our clinical study. This is again a global effort in Australia, in Canada, New Zealand, and of course many centers in the US, so that we can actually rapidly move forward. So with that, I'll thank you and close and take any questions.